welcome people that are just joining. As the room kind of fills, the online room fills up, we'll just give it a minute or two as people join. Thank you for being with us. Please do introduce yourselves in the chat, where you're from, if you feel able to. Okay, let's get started. Thank you ever so much, everybody, for joining us again this afternoon, and really appreciate you giving up some of your weekend to be with us here at Friends for Life. My name's Chris. I'm just here to introduce the session, and also at the end to ask any questions on your behalf that come out of the chat or the Q&A box to our speaker, Fiona Kennon. Fiona, thanks ever so much for being with us. And we're really looking forward to this session, talking about those kind of difficult conversations in families and how we can try and get better at them. Kind of deep personal experience, and but also professionally is a qualified teacher who has now added expertise in family therapy. So she works and researches in the area of systemic family therapy, with a particular interest in how that works for people with type 1 and their families. So we're really lucky to have Fiona for all of those reasons. This is being run as a webinar, so please do put your questions in the Q&A box, which you'll find, most of you, depending on what device you're using, probably at the bottom of your Zoom screen, or use the chat, and we'll make sure there's some time for questions at the end. We are kind of going to be dealing with some sensitive subjects and some so please be aware of that, but also I think it's fair to say that in this kind of virtual Zoom setting, where Fiona's not going to be in a place where she can give kind of individual.
So I'm not sure now whether I have dropped out or you have dropped out, Chris. Jen, are you there?
I'm here. It's Chris's connection, so I'll pass over to you, Spotlight, Fiona.
Okay. So hello, everybody. Chris has had to leave. I think it's his internet that's dropped out. Hopefully he'll come back and join us, but I'm not sure how much of that you heard, but certainly I think what he was saying was that I'm happy to take questions at the end. And I hope that this will be a helpful presentation this afternoon. And I've called it Jelly Babies. Oh, no, I was hoping my jelly babies would move around. They're meant to jump about the place, but they've stopped. So we'll not try that again. I've called it Jelly Babies, Jelly Beans, or Haribo because I suppose I was thinking about that idea of getting to the same place in terms of treating a hypo, but there being more than one way possibly to get there. So that's the idea behind the name. And we're going to be talking about ideas of safe uncertainty. My 24-year-old son sent me a text this morning. He was the IT consultant on this particular PowerPoint. He got the jelly babies to jump. And he sent me a message this morning that said, "Mum, I feel safely uncertain that your talk will go well, but just remember that to tell everybody that you will explain what safe uncertainty is." So I am going to do that. It's part of the hopes, in fact. So, oh, they were jumping there. Let's move on now. So we're going to talk a little bit about context for you and your young people with type 1, and think about sameness and difference. We're going to think a little bit about how you create some safe uncertainty in life with type 1. And particularly towards the end, I'm going to share with you some thoughts about type 1 and eating disorders, because there's a significant correlation that I think people need to be aware of. So as I said, questions at the end or via email, which I'm happy for people to use. So a little bit about me and my context. I'm Fiona. I'm married to Steve, and we have 3 young adults. And I am, as Chris told you, a systemic couples and family therapist. I have had type 1 since I was 8, which was in 1977, so 44 years ago now. And my job is working as a family therapist in a large mental health hospital in the northwest of England. And I work with adults, so 18 and upwards, and their families, where there is an eating disorder present. So these are people who are very unwell because they've been admitted to a mental health hospital because of their eating disorder. And today I find myself in the slightly novel position of having a surname that appears to be reasonably common. It's not a law firm, it's not Kennon, Kennon and Kennon. It is in fact a diabetes connection. So when I met Steve 35 years ago in this beautiful city of Glasgow, I went home for the first time to meet his family, and his brother Brian was about to apply to study medicine. And we went for a walk up a hill in Dumfries, and halfway up I went hypo. And in those days I used a Mars bar to treat a hypo, not jelly babies. And Steve continued up the hill as I sat eating my Mars bar, and Brian sat beside me and was really, I think, surprised, and would tell you that he had been quite taken aback at that it was food that made me better and not medicine, not some sort of medication. So I guess what we're thinking really is that now we know that that idea of food and medication has been expanded by the research that we now know about that wasn't available certainly when I was diagnosed. And we know that there is a huge psychological and emotional aspect to living with type 1. And of course, we can see what's going on in the body. We can see what insulin does, what food does, what exercise does. But what we can't really see is what's happening in people's heads. And I think that's a really important thing for us to remember and to think about. Oh, that's our dog, Nessie. So family therapists think about context, and they think it's really important. And I wanted to talk a little bit about that today before we go on and think about some tools really for having conversations, creating a safe environment for conversations. So this is Maslow's hierarchy of needs, and Maslow was a psychologist who said that people can only attain their true potential, which is the top of the pyramid, if all the other things from the bottom up are in place. So physiologically, that you would be fed and watered, and then that you would be kept safe. And it's the safety one that I want to think particularly about this afternoon. And I suppose that when we think about that as parents, we know that the safety of our young people is paramount. So once they've been fed and watered, it's their safety. And in the context of diabetes, it's their health, it's their safety to live healthily. In my work context, of course, that whole thing about being fed and having your physiological needs met is missing. And it's only once people are admitted to hospital that their parents can move into looking at the safety, which is very often the conversations that I would have with parents and young people. For young people, their safety comes with an acceptance and a sense of fitting in. So I think everybody's thinking about safety, but they are imagining it in different ways. So parents are thinking health, well-being, young people are thinking being accepted, fitting in. And a problem for parents can be, and adults can be, that we do tend to be able to see the bigger picture. In fact, Chris and I and Jen were talking about that before we came on, that actually we as adults, as people who've lived and have some life experience, we have a better idea perhaps, or we certainly think we do, of what is important going forward for life. Whereas young people very often are filled with enthusiasm, with a sense of being possibly invincible, and they live in the here and now, and that's a good thing. That's something we don't want to squeeze out of them. But I think it can be very difficult when you live with type 1, because the message is, think of the future, think of the future, think of the future. It certainly can be that. And so, yes, we do want them to think of the future. We also want to recognise that they're living in the here and now. So how do we have these conversations that don't miss each other when we're all looking for the same thing? What are we trying to do, really? So I popped this quote in, which I absolutely love, a Mark Twain quote, because I think having 3 young people at 24, 22 and 18, we're just getting to the point where perhaps they recognise that we have learned a lot in the last few years, but this does, or can certainly sum up for parents, I think, what can be difficult when they try to tell their young people. So what we're really looking to do is create a space where people can hear and experience. And the temptation is to do that with a level of certainty. So the temptation for parents is to say, if you do A, B will follow, you will be safe. If you follow the rules, if you take your insulin, eat your food, you'll be safe. If you don't touch alcohol, you'll be safe. If you avoid sugar, your control will be perfect and you will be safe. You're getting the picture here, I think. And of course, if we extrapolate that out, we get to the point where what we're actually saying is, if I can keep you here wrapped in cotton wool, I will keep you safe. And we know that that's not realistic. So if we promote that idea or that message that type 1 is perfect, all will be well, we're in danger of encouraging perfectionism. We're in danger of alienating young people and perhaps leaving them feeling guilty and inadequate, because realistically, it's not possible to have perfect control. And we know that it doesn't work. So that's the real danger of a position of certainty when we want to think about safety. What we're really looking to do is to maintain safety, because that parental desire to be safe, to keep your child safe, that's a good thing. It's not something we want to discourage at all. But we also want to create space for there to be uncertainty within that safety. So people are going to be allowed to experiment, for example. They're going to be allowed to take some risks. They're going to share their responsibility for their type 1. You are creating a family environment where people are going to take over the responsibility for their type 1. That could be very difficult if you've looked after them very well. And that's been your responsibility for a long time. And we're thinking also that young people will make mistakes, so that they can't get to that position that perhaps you and I are in now, where we don't get anything wrong because we're older and wiser. A lot of our learning is experiential. So how do we think about making it safe for people to take risks? Well, I don't have all the answers. I have some ideas, which I would like to share with you, and I hope that they will be helpful. And I suppose I should say to you, I wish I did have all the answers. It would be so helpful to you and to me if I could just say, do it like this and it will be fine. But what I can say to you is that you are the experts in your families. You know your families. It may not always feel like that, but you know your families far better than I do. So I might have some ideas which may be more or less helpful. And I guess this is an invitation to you to take what you think is helpful, ignore what you think isn't, but to know that you're the experts, and there is a confidence that comes with that will be helpful. And on that note, the very first thing that I would be encouraging you to do as parents and grandparents perhaps and carers is to model what it is you want to encourage. So we've talked about the fact that type 1 can be a huge emotional and psychological pressure. That's not just for the person who's injecting, that's for everybody in the family. If you bottle it all up, don't talk about it, don't acknowledge it as a problem, your young person will know that that's not the case, and they will not quite understand. They will sense, and I see this all the time at work, they will sense that you are not being congruent with how you feel. So while I'm not suggesting that you pour out your woes and worries to them at all, I am saying find somewhere to look after yourselves. Take time to look after yourselves. First and foremost, if you were on an aeroplane today and the oxygen masks fell down, the crew would be saying, tempting as it is, don't put on the oxygen mask to yourself first. Sorry, don't put on the oxygen mask to yourself first, which is the opposite to what you might be tempted. You might be tempted to put it on your child next to you or the old person on the other side of you. Don't do that. Think of yourself first, because if you don't look after yourself, you can't look after everybody else. So find a supporter or more than one supporter. Perhaps it's your spouse, perhaps that's a parent, perhaps it's a friend, someone who's prepared to be there to listen, to help you think through the issues that come with parenting someone who has type 1. The next thing is to validate, praise, validate, praise. And I'm bringing this in really because I had a long conversation before I wrote this talk with a woman who lives with type 1 and an eating disorder and has extensively researched and thought about some of the issues that come up for people. And we talked about the fact that we need to encourage our young people to see themselves as more than just their illness. So it's tempting, isn't it, when you're at school and you have a card to get out of lessons because you're going hypo, when you've maybe got a sensor in your arm, a pump and you're attached to you somewhere else, where you can't do PE this week, or you have to postpone your sitting your hires for 2 hours because your blood sugar's out. It's tempting to be very different and for your diabetes to be setting the context for you. What parents and family members need to be doing is to validate and praise their young people for what they manage to live with on a day-to-day basis. And that needs to be really thought about. It's not empty praise, it's thought about praise. The next idea would be to think about what it is that you want to have these difficult conversations about. So this idea of baskets, I think, can be quite helpful for families. So it might be that you have a list as long as your arm. I certainly have had, possibly still do, of things that really, really bug me about my young people that I want to talk about. And that can be everything from not turning your socks the right way around for the dirty washing to possibly not taking your insulin when you need to. Clearly, these have all got different priorities, but if we, and it's tempting, or it is for me, if we throw everything into the one conversation, our young people will switch off. We know now that brains for young people are not fully developed until the age of 25, and they are not physiologically able to take on board all of that feedback at once. So if your conversation is about not turning your socks the right way around, try to keep it about that. If your conversation is about not taking your insulin, try to keep it about that. Think about baskets. What needs to be in my small basket of things to talk about, and what can I leave in the big basket for another day? And a good idea when we're thinking about these conversations also is to think about striking while the iron's cold. When I was putting this together, I could see Duncan sniggering in the corner. So I am telling you this and saying to you, I recognise that that can be difficult to do. I find it difficult to do, to maintain my calm or to walk away when things are beginning to get heated. But actually, there's far more likelihood of people being able to hear the conversation if we come back to it when emotions have settled. And the key thing with that is to remember to come back to it. So you're not giving away your expertise. You're not giving away your thoughts and your life experience. You're not being asked to stop caring about people's safety or well-being. You're saying to your young person, jelly babies, jelly beans, haribo, I want to get to that point of being able to talk to you about this important thing. This is not the time. I'm coming back tomorrow to talk about this. Or we'll talk about this tonight when everyone has calmed down. Let's make a date and I'll see you at 6 o'clock or whatever suits you. So crucially, coming back to it, but picking your moment. Oh, you're, I think, maybe getting the message here about validating and praising. Noticing, recognizing and reframing. So I think particularly when people are living with something like type 1, there is that extra burden. And you have to work a bit harder to get things as good as they can be. And I think it is really important that the people round about that person notice when things are going well. Not only do they notice, but they also recognize how hard it is. And they find ways of taking that praise and turning it into something usable. So for example, I saw that you really managed that conversation with so-and-so about your diabetes. Gosh, that's given you so many more skills for being able to have difficult conversations, for example. I was really proud of the way you conducted yourself when you asked to eat in that particular situation and you explained. You really are good at doing that sort of thing. So noticing and backing it up with something. You know, that I suppose is the validating and praising. Oh, here we go again, validating and praising. Am I on to something here, do you think? Something also, I think, important about young people knowing that you have these conversations about them with other people. So finding opportunities to be overheard, possibly having a positive conversation about your young person with someone else. So it's not just with them, it's about other people, so that they know that you are thinking this and talking positively about them and their diabetes to other people. And it's important to say that we're not ignoring the problem. That's not what we're doing. What we're trying to do is create a context that when issues come up, we can openly discuss them and not sweep things under the carpet, which I think it can be tempting to do. And certainly the families that I work with would say to you, we don't want to make things worse. We feel like we're walking on eggshells all the time. And the temptation with that is, we better be quiet. We're getting it wrong. We're making it worse. We don't know what to say. Actually, a reframe, you who have lived as parents and carers of someone with type 1, you have kept going and kept going and kept going. So you're able to do that. It's just a slightly different context. Oh, and we're validating and praising again. So I suppose those were the tools really that I hoped would be able to come out of the conversation about having conversations, the talking about talking, which is what you're doing at home. And that might not all be about diabetes. And I think that's really important. These are ideas for any kind of conversation having with young people and teenagers. And if you're fortunate enough to be starting with 8-year-olds, 9-year-olds, these are things that you can put into place before your children get to that stage, that normal adolescent detachment stage that we want them to go through so that they can live with their type 1 safely and you don't have to wrap them in cotton wool and keep them at home. So the last sort of 10 minutes that I'm going to talk for, I wanted to talk a little bit about type 1 eating disorders or diabulimia. And I wanted to talk about this because I have done some research into parental experiences of this awful condition, and there is a significant correlation between eating disorders and type 1 diabetes. And you can see here a physical correlation. So the picture, I hope on your left, certainly on my left, is of a young girl prior to diagnosis with type 1. And on the right is the same girl after insulin therapy. So you can see, and it does not too far to stretch a point to think that if you're 14 and you've not been feeling very well and things have been going downhill at school because you can't concentrate and you're not sleeping because you're running to the loo and you're losing weight, and people, as they do with all the best intentions, are saying, oh, you look well, have you lost some weight? Oh, you look well. And then you're given this injection. You've maybe had a crisis before your diagnosis. Suddenly people are handing you needles and saying you're going to live with this for the rest of your life. You're not going to be able to do this. You need to think about the future. This might happen. This might happen. Everybody's emotion is running high. In my case, my grandpa cried. I never had seen him cry, and I never saw him cry again. So there's lots of emotion and uncertainty going on there. You can imagine what it might feel like if the one sort of positive that potentially came out of things prior to your diagnosis, which was people saying, oh, you're looking well, suddenly you're taking this insulin and you've put on weight. You can see that your view of insulin might not be, well, actually, this is a good thing, even though we know it is. So that was the kind of physical correlation between insulin and weight gain. And this is the kind of practical relationship. So on the left of your screen, what you can see at the moment are 6 things to look out for, which were published by BEAT, which is the eating disorder charity BEAT. And this was on a poster that was sort of stuck to the back of toilets all over the place. If you're concerned about an eating disorder, are you concerned about an eating disorder? Does your young person tick any of these boxes? So recording weight regularly, encyclopedic knowledge, exercise planning, blah, blah, blah. When we look on the right-hand side of your screen now, this is what the person with type 1 is experiencing. So potentially 4 outpatient clinic visits a year where their weight is regularly being recorded. Daphne, which is the education program in the UK, which you certainly had to do before you got an insulin pump, encourages your carbohydrate knowledge. And in fact, we have a bit of a joke at work. My colleagues will quite often go over to Sainsbury's behind where I work and bring back something and say to me, right, Fiona, what's the carbohydrate content of this? And it's one of my boasts. Never yet have I been more than 2 grams out. And because I have to have that understanding of carbohydrates. I have to plan any exercise that I do carefully. I know that if I eat fewer carbs, I have better overall glycemic management. Diabetes.co.uk, which is an online website and chat place for people with type 1, suggests that if you're going off a bit, you keep a food diary. And of course, preoccupied with thoughts of food, well, I'll not be the only person here to know that, you know, if you're going hypo, you could eat the kitchen. I don't leave the house without my jelly babies. So I think what I'm trying to say here is you can see why there is such a connection between eating disorders and diabetes, and why, if you're being treated for an eating disorder and you also have type 1 diabetes, it's extremely difficult to pull these two things apart, to disentangle them, because in one case you're being encouraged not to do those things, and in the other case you're being encouraged absolutely to do those things. So type 1 and an eating disorder has been around for a very long time. Emitting insulin in order to lose weight, as you can imagine from those photos, is very effective and very, very dangerous. However, it is really more recently where people have begun to, professionals, I think, have begun to say we can't tolerate this any longer. And so these are some of the things that are going on at the moment to try to find an intervention or support for families and young people or any age group of people who are in this situation. And I'm going to go from the bottom up, really, because DWED, which is a charity, Diabetics with Eating Disorders, really has pushed this agenda. they have been the people who have brought type 1 ED to every conversation about diabetes. They have pushed their way in there. They have really banged the drum very effectively. Spearheaded by 3 women who set up the charity, all with type 1 and an eating disorder, 2 of whom had died by the time they were 30. And the one who's left, Jack Allen, is an amazing woman who has complications, but is now studying to be a clinical psychologist at the age of 40, and who has brought this into the national agenda. Unfortunately, DWED itself has taken a bit of a hiatus really during her training. I think she had hoped to hand over the reins to 4 of us who were keen to support, but because she had organically grown it, there was too much information to hand over. So there is still a website that you can go and visit with information, and crucially, there are Facebook support groups where people can join if they are concerned about their family and friends, or another one that you can join if you're experiencing this problem. And it is peer support, mainly, with some ideas about what to do. The other thing that's going on is a Diabetes UK funded study called Priority. I have seen this and it looks good. It is creating an approach really to be used in pediatric diabetes clinics, I understand, to help people to think in advance of disordered eating problems starting. And it's a kind of manualized approach, and I think that that will be good. And apart from that, yes, it is definitely being more recognised. I wish that I could say to you, do this and it won't happen. But I do think that there is something that we all, as parents and adults involved, can do, which is to promote health over weight. So the evidence tells us that women with type 1, there isn't evidence for men, but women with type 1, on average, will be 15% heavier than their non-diabetic peers. So already, any ideas that you might have about the healthy weight of your young person has to be changed really in the light of that evidence. So what I think people are finding helpful is to think about a story of be healthy rather than be a certain weight. And it is definitely worth taking that approach with your young people. And if you notice that that's not happening in your diabetes clinic or at the GPs, more likely that you say something about that, that you take an expert position and say, that's not a helpful approach. Because we want to support our young people to be healthy in all aspects. Weight is part of that, but we also don't want terminal thinness or terminal fatness. We want healthiness, really. So just before we finish, and I take some questions, it's been a bit of a whistle stop. There are a few places that you can go to educate yourself about eating disorders and diabetes, if that's something that you feel you want to do. Your diabetes team would be the place to start if you have really active, significant concerns, rather than your GP. And if necessary, insist. I think most diabetes teams now are well aware of what's going on and what can be going on. So I don't think that you will be ignored there. There is a good, or there certainly was a good BBC 3 programme about someone's experience. There's a really good book, Prevention, Recovery from Eating Disorders, Injecting Hope. I like that title. And that is a really accessible, easy to read book, which is not all about this is dangerous. It also talks about how people have recovered. There's DWED, as I mentioned, and Diabetes UK have got a diabulimia page. It's quite generic, but it's worth going there too. So I haven't included in this presentation references about the evidence for eating disorders and diabetes or any of that. I thought that was, I have got those if anyone wants to see them. But I hope that this has been informative, not too much information. I have a feeling I might have overloaded, but I felt like I was trying to fit into 45 minutes what perhaps would have been an hour if we'd been in person. And I hope that you will have found it helpful. So thank you for joining.
Thank you, Fiona. Certainly what I've picked up from the chat is overwhelmingly kind of positive and grateful for introducing, well, not introducing, but talking openly about this subject. We do have a few questions, which probably not surprisingly are on the latter part of your presentation mainly. There was one specifically about binge eating disorders, and whether you could say a little bit about that as well. Someone saying that is something which also can be associated with type 1.
That's correct, Chris. And of course, we can imagine exactly why, because so that can be because people feel they want to starve themselves and then they binge. So that would be more likely in people who don't have diabetes. But of course, as I said, when you're going hypo, there can be a temptation to eat the kitchen, really, if you could. And so that very much is an association. And again, there isn't I can't say to you, do this and all will be well. However, I absolutely would be going to the diabetes team if that is something that is happening to you and saying to them, can you help me? Can I get some sort of CGM? Is there some way of preventing the hypos so that I'm not tempted? We have tools at our disposal now, which we would not have had even 10 years ago, that might be able to help people and prevent the hypos, which set off the cycle of binge eating, which I think a lot of people who suffer from binge eating in diabetes would say was the trigger point for the cycle. So I would be certainly saying to the team, is there something we can do about this electronically or technologically that might make a difference?
Okay, thank you. We've got two questions, I suppose, which are about the scope of this issue. One about whether it's something that occurs with boys as well as with girls, and then a second question about whether celiac has an impact here, or whether the impact, I suppose, is potentially greater for those that are diagnosed with celiac as well.
So I'll answer that one first. So certainly in our, I haven't come across anyone yet, and I do have quite a lot of experience in terms of supporting the DWED pages, but I haven't come across anyone in my inpatient setting who also has celiac disease. However, it would stand to reason that is yet another restriction on your eating, which you can imagine would cause problems when diabetes and eating disorders and celiac disease all come together. And the management of that would be really the same for diabetes, that you would be wanting to speak to your team, you would be wanting to see if there was specialist help available. It is really important, and this is what all the evidence overwhelmingly says, current interventions so family therapy is a huge intervention in eating disorders. Nice guidelines, that's what is promoted. What we know is that those interventions that are for eating disorders do not work with the eating disorders and diabetes population. And this is why these, see if I can go back a page, these studies that are going on are really important because they're looking for something specific to diabetes. And what NICE guidelines say, and one would like to think that it's being followed, I'm not entirely sure that it is. What they say is that you should make sure that you are being managed by people who understand diabetes. And that would be my experience in an inpatient eating disorder unit, is that the people are there as specialists in eating disorders. They are not there as specialists in diabetes. And that's what we need to try to promote, is people who have an understanding of both conditions, because there is that, do we give control of insulin back to the patient? Well, you're going to have to do that for the patient to be discharged. But actually, if you give it back to them and they start squeezing the insulin back out after they've injected, what do you do with that? So we have to think outside the box. And you asked me another question, I'm afraid I can't remember what it was. It was celiac. Boys. So yes, so there is evidence to suggest that 60% of young people are manipulating their insulin. to lose weight. And I guess I don't want to sound too scary. There is less evidence about boys, but I suspect that that is because boys and eating disorders, although it is definitely a thing, is less of a thing than girls with eating disorders. But I think we're just on the cusp of seeing that come through. So in a unit that takes 30 patients at any one time, we might have, of those 30 patients, 10% might be males. I think that anecdotally, from the evidence that I hear from consultants that I know, from talking about it in my own diabetes clinic, it's an eeksy peeksy sort of thing, but the actual research hasn't been done to give you the numbers.
Okay, thank you. We've got a couple of questions where I'm afraid, in my ignorance, I don't know whether these are questions which you will be able to answer or not. So I'll read them out. But so the first question is: would affidavits be associated? Do you have any advice regarding that with type 1?
So is this to do with healthy eating? Perhaps the person can come back and explain. Do they mean healthy eating, clean eating?
Okay.
Yes.
So Jenny, who asked that question, if you're able to, that would be great. So the other question is about if you had any thoughts about something called Superlife STC30 and diabetes.
So I don't know what that is, Chris, so I couldn't comment on that. I'm happy to explain.
That's okay. That's okay.
The other question is about this idea of green eating, this healthy eating. And again, as much with people with type 1 as with people who haven't, but exacerbated by the type 1, as that I hope that helpful beet and diabetes sort of combination showed. Anything that encourages that slightly obsessional way of eating can be, or anything that encourages and invites you into more of an obsessional way of eating. So there's nothing wrong with eating healthily. That's a good thing. It's when it's then multiplied by the force multiplier of diabetes, very quickly these things can get out of control. So if you are living with a young person who is perhaps saying, I want to be a vegetarian, great. I want to be a vegan, okay, that's fine. Now I want to eat green, okay, that's fine. We're also looking at that and thinking, is this about being healthy, or is this about taking this to a new level, which is an eating disorder? And what the people that I work with would tell you is that often eating disorders are associated with control. So it's not necessarily about control of diabetes, although that might be something that you want to control, but it might be that other things are out with your control in your life, one of which might be your diabetes and how you live because you have a diagnosis. And so being able to control what you eat and lose weight into the bargain and have people say to you, oh, you're looking well, oh, you're looking well, actually seems helpful. But unfortunately, quite quickly turns into something that you think you're controlling, and then it becomes about it controlling you. And it is about helping people to recognize that there is a danger of that, I think, and focusing on the healthy. So if you are experiencing that with your young person, that you would perhaps be involving the dietitian in the diabetes clinic to talk about what is healthy with diabetes, because the rules, whether we like it or not, the rules are not the same for us as they are for other people. If you have type 1, you do have to be thinking about more. So that would be my advice. Be aware of the fact that these are good things to be thinking about healthy eating. However, very quickly they can turn into bad things. So the healthy can be unhealthy if we're not careful. And if you as parents are worried, involve the team, involve the specialist dietitian who should have some experience of this.
Okay. Jenny has helpfully come back. So what I read out as affidavit was one of those text autocorrect things, which didn't go very well. Avoidant restrictive food intake disorder was what got corrected.
Yeah. So, and that's very often about healthy eating.
Okay. Lots and lots of really positive comments, Fiona, on what what you've been opening up on and how helpful that is to people. Could we finish off with one question back on the kind of the first 60% of your presentation? For anybody particularly for whom just wants to focus on the more general things. Could you say a bit about kind of any tips for building skills and competency in good conversations to kind of build up something in the bank for when the more difficult conversations come in families?
So I think that my real advice would be, don't avoid emotion. If you had to ask me about the families I work with, the biggest general issue is people not talking about emotion. So I'm working with a family at the moment. The young person's 18. Mum and dad, delightful, want the best for their daughter. When we talked a little bit, so her biggest worry about family therapy is that she's going to upset them and they're going to feel like bad parents. And I said, what happens in your family when people get upset? And Mum said, well, I don't get upset in front of the children. I leave the room before I get upset. And I said to Dad, what do you do when Mum gets upset? And he said, well, I just leave her to it. And you can see that completely inadvertently, and this is not a blame comment, goodness me, I'm a parent and a wife and all the rest of it, but completely inadvertently, talking about emotion has become a complete no-no in that family. So, and that is something that I experience all the time in my job. People don't know how to have conversations about how they feel about things because people want to fix it. And we can't always fix things, but we need to be able to acknowledge them. So my real advice to every family I work with is be able to have conversations about things that are difficult. Start with the general conversations, have meals together, spend some time with your children and your young people. It's difficult, life gets in the way, but this is part of creating life that's positive going forward. Be encouraging healthy, be noticing what they're doing well in all contexts, but particularly let it be okay to have emotions. It's okay to be angry, it's okay to be sad. Might not be able to do anything with that. We need to just notice it, validate it, and be able to talk about it so that when they get to that age where they really don't want to listen to you because you really need to learn, as Mark Twain said, you have got something in the bank. You have shown yourself to be their supporter, not to the point where anything goes with boundaries, but you are their supporter and they can trust you when everything outside is all over the place for them. You can be their supporter. And I think that then you will have something in the bank and that will make a difference.
Great. Thank you. Thanks ever so much. We've had so much kind of, the chat has been really full in an unusual way for this session, but in a 100% positive way. People have really appreciated you opening up on what is obviously an important subject, but a difficult subject, and one which is kind of undercovered, I think, in terms of advice to parents and families. So thank you for your kind of general advice on tackling difficult subjects, and then more specifically on the eating disorder one. And I'm sure that it's one of these sessions that if we ran it for 3 hours, I think we still wouldn't exhaust the conversation. So thank you ever so much, Fiona, and thank you to everybody else for joining.
Yes, thank you for joining.
And we really appreciate it and look forward to sharing with you the rest of this conference. Thank you, everybody.
Thank you.